Vice Chancellor Dr. Ajit Gulati, Pro Vice Chancellor Dr. V.K. Kapoor, Principal Dr. M.D. Soni, Senior Faculty Members, colleagues, and students. I welcome you all to the 13th UGCR, topic for which is blindness. Now, since it's a vast topic, we have divided it into two parts. Today, we'll be covering the part 1, which will comprise of the anatomy, the physiology, the epidemiological aspects of blindness, causes of blindness, and cataract. The chairpersons for today's UGCR are Dr. Chaitanya Prakash Gupta, Professor and Head Department of Ophthalmology, Dr. Jaya Devendra, Professor, Department of Ophthalmology, and Dr. Rajat Vora, Professor and Head Department of Community Medicine. Moving forward, I would like to invite Dr. Chaitanya Prakash Gupta, Professor and Head Department of Ophthalmology, to give a brief introduction on the topic blindness.
Sir, senior faculty members, colleagues and dear students, and also Dr. Aaradhya Gupta sir, who was also my teacher during SMS. So today's topic is blindness. We have 5 senses in human body, which one are the smell, touch, taste, hearing and sight. Out of these, sight is very most important senses, which also affect other senses of body also. Blindness significantly impacts quality of life, independence and mental health of not only individual but also the whole family and surrounding society, and leading to challenges in daily activities, employment and social interactions, with potential for increased risk of depression, anxiety and falls and injuries. By definition, there are two terms, visual impairment and blindness. Visual impairment means visual acuity between 618 to 3/60 on Snellen's chart. While blindness is the vision in better eye less than 360 to no peer, means no perception of light in better eye. So visual impairment is reduction in visual acuity or field of vision that cannot be fully corrected with standard glasses or contact lenses, while the blindness is a severe visual impairment where there is complete lack of vision or a very limited visual field. Other defined as having visual acuity less than 3/60 or worse on Snellen's chart. India changes the definition of blindness, means the visual acuity less than by 360 or the field of vision it should be less than 10% of field of vision. There are some goals by WHO to reduce the incidence and prevalence of blindness. So there is globally there is 43 million people affected from blindness up to data 2020, and there are 7 million new cases per year. In India, the prevalence reduced from 1% to 0.36% up to 2019 data, and total cases decreased from 12 million to 4.8 million. There are main 5 leading causes of visual impairment and blindness. These are the uncorrected refractive error, cataract, age-related macular degeneration, glaucoma and corneal opacities. We will see in this slide the out of total cases, 80% blindness is avoidable or preventable by the measures taken by us. So we divided the causes again 3 categories: preventable causes, treatable causes, and the causes which needs higher consultation or evolution. In preventable causes, we see the vitamin A deficiency, glaucoma, onchocerciasis, uncorrected refractive errors, and occupational injuries. While in treatable class, we see the cataract, which is fully corrected by surgical intervention, glaucoma, which can be controlled, diabetic retinopathy, corneal opacity, refractive errors. While the causes which need higher consultation are age-related macular degenerations, retinitis pigmentosa, optic neuropathy, congenital blindness, and uveitis. These are the academic causes, but other than academic causes, the more important are the contributory factors which lead to blindness. One is the ignorance ignorance to the eye symptoms. Usually patients ignore the symptoms in early stages and they delay in treatment. There are many diseases when they get delayed in treatment, we can't restore the full vision. So this is one of the more important cause of the blindness. Another is the treatment defaulter. In few diseases like glaucoma, age-related macular degeneration, we need the long-term treatment and follow-up. Some patients get irritated or due to the lack of money, they leave the treatment in between and they go to the stage of blindness. Third is the poverty. As we know in developing countries in India, money is the main factor for the treatment. There are many NGOs, Government of India and WHO have many programs which enable us to fight against the blindness. And another causes in rural areas are the belief in other methods of therapy. They take local treatment, start steroid drops from medical soaps, and that will lead to blindness. How to we fight against the blindness? Only the prevention of trauma by wearing protective measures during birth time, judicious use of steroids. Secondly, the early detection, especially in cases of glaucoma and age-related macular degeneration, we need to detect the disease at early stage. That is the only method to prevent or delay the blindness. Screening for the refractive error, myopia and retinal pathology like hypertensive retinopathy and diabetic retinopathy. And timely treatment. As we know, cataract is fully treatable, we can restore the full vision, but some patients wait up to the maturity of cataract, which is not a good sign for them. And if they are treated at early stage, they will get the good vision. Infections and retinal pathologies, they give the timely treatment and patients get full vision. Why this topic is important for UG level? Because you are the future of ophthalmology, you are the persons who will fight against blindness in future. Many of students will get the ophthalmology branch in PG, or whoever not will do PG in ophthalmology. They will also help to fight the blindness at primary healthcare centers, secondary and tertiary healthcare center. So every student at UG level must be aware of these three examination postings: examination of visual acuity, which will help the patient when to refer, when not to refer; intraocular pressure, which is the important sign of glaucoma. The glaucoma is the disease in which we cannot restore the lost vision. It is the disease only we can control or we can prevent the further damage of the vision. So timely intervention is very, very much important in this disease. And fundus examination. If you are able to see the fundus of patient at your level, you can refer the patient, especially the diabetic retinopathy, hypertensive retinopathy. In these cases, it is very important.
Good morning, dignitaries, esteemed faculty members, and my fellow colleagues. Today, under the guidance of Dr. Pankaj Kumar Singh, Sir, Professor and Head Department of Anatomy, under the moderatorship of Dr. Runjun Vijayan Varghese Ma'am, Assistant Professor in Anatomy, along with Palak Garg, Parangat Agarwal, Yashaswini Chaudhary, Yashoda Vishnoi, and I, Aaradhya Bainada, would like to present on the topic Blindness, the Anatomy of Eye. We will be discussing the anatomy of eye under the following headings: covering of eyeball, compartments of eyeball, lens, extraocular muscles, optic nerve, and clinical anatomy. The eyeball is spheroidal in shape with its anterior-posterior diameter being 24 mm, horizontal diameter 23.5 mm, vertical diameter 23 mm, and refractive power 60. The eyeball consists of three concentric coats: the outer fibrous coat, the middle vascular coat, and the inner nervous coat. The outer fibrous coat is further divided into cornea, limbus, and sclera. Cornea, it is the anterior transparent 1/6 part of the outer coat. It allows the light to enter the eye and it also reflects the entering light. It is avascular. It bulges forward from sclera at the corneoscleral junction called limbus. It is highly sensitive and it is supplied by the nasociliary nerve, which is the branch of the ophthalmic nerve. Cornea consists of 5 layers from outward to inwards. It is epithelium, anterior limiting lamina, the stroma, the posterior limiting lamina, and the endothelium. Thickness sclera, it is the posterior 5/6 part of the outer coat. It is opaque and is seen as the white of the eye in the palpebral fissure. It functions as it maintains the shape of the eye. It provides attachment to the muscles which move the eyeball, and it also protects the internal structures. The thickness of sclera varies. As we can see, it is thinnest at the equator, thickest at the back, and it is weakest at the point of emergence of the optic nerve. The sclera is pierced by the following structures. It is pierced by the optic nerve near to the inferior medial to the posterior pole of the eyeball. Posterior ciliary vessels pierces it near to the optic nerve, and anterior ciliary vessels pierces it near to the corneoscleral junction, and 4 choroidal veins pierces it just behind the equator. Middle coat is often called as the vascular coat as it consists most of the blood vessels of the eyeball. It consists of choroid, ciliary body and iris, and these 3 together are called uvea or uveal tract. Choroid, it is the posterior part of the vascular coat. It is brown, thin, and it lines the inner surface of the sclera. It is connected to iris by the ciliary body anteriorly, and posteriorly it is pierced by the optic nerve. Ciliary body, it is the thickening in the vascular tunic. It is connected to choroid in the back and in front to the iris. It is situated posterior to the corneoscleral junction. Ciliary body consists of 2 parts, the ciliary process and the ciliary muscles. Ciliary process are a group of 60 to 90 folds which lie on the inner aspect of the ciliary body. They are a complex of capillaries and cuboidal epithelium. They help in secreting the aqueous humor. The ciliary muscles are 2 types, the inner circular fibers and the outer radial fibers. These fibers help in maintaining the shape of the lens and also helps the lens to focus in the near vision. Iris, it is the contractile diaphragm located between the cornea and the lens. The opening in its center is called the pupil. It is attached at its periphery to the middle of the anterior surface of the ciliary body. Retina, it is the innermost coat of the eyeball. It covers the 3/4 of the inner wall, and its thickness varies from backward to forward. It consists of 2 layers, the outer pigmented layer and the inner sensory layer. The retina is further divided into central retina and the peripheral retina. The central retina consists of the fovea, parafovea, foveola and the perifovea. The fovea, it is the part of the retina which has the maximum concentration of cone. The macula, it is the pale yellowish area near the posterior pole of the eyeball. Parafovea, it is the small portion of retina which is responsible for clear central vision, and foveola, it is the center of fovea and it has the highest visual activity. Peripheral retina, it is the part of the retina which is outside of the macula. It consists of far periphery, mid periphery, optic disc and ora serrata. Ora serrata, it is the serrated junction between the retina and the ciliary body, and optic disc, it is the point where the optic nerve begins. Retina consists of the following 8 layers from outward to inward: the retinal nerve fiber layer, the ganglion cell layers, the inner plexiform layers, the inner nuclear layer, the outer plexiform layer, outer nuclear layer, and the photoreceptor layer, and the pigmented epithelium. Now, with the help of a video, we will see the functioning of the layers of retina. As light enters the eye, it strikes the receptor cells of retina called rods and cones. The light triggers the chemical reaction in the cell, which then sends the electrical impulse with the optic nerve to the brain. The eyeball interiorly is divided into two compartments, the anterior compartment and the posterior compartment, and these two compartments are divided by the lens. The anterior compartment is further divided into the anterior chamber and posterior chamber by the iris. As we can see that the anterior chamber, it is the small chamber and it lies between the iris and the cornea, whereas the posterior chamber lies between the humor. Lens, it is the transparent biconvex body. It is 1 centimeter in diameter and 4 millimeter thick. It is located between the anterior and posterior compartment of the eyeball. It is attached circumferentially to the muscles associated with the outer wall of the eyeball. The lens has 4 structures: the lens capsule, the epithelial cells, the lens fibers, and the zonules. The eyeball consists of extraocular muscles which are located outside the eyeball and inner the orbit. The eyeball is further divided. The extraocular muscles are further divided into voluntary muscles and involuntary muscles. The involuntary muscles consist of superior tarsal muscle, inferior tarsal muscle, and orbitalis. The voluntary muscles are of 2 types: the recti muscle and the oblique muscle. Recti muscle are superior rectus muscle, inferior rectus muscle, the lateral rectus, and the medial rectus. The oblique muscle consists of the superior oblique and the inferior oblique. These muscles help in the movement of eyeball and also they help in the binocular vision. Optic nerve, it is the second cranial nerve. It is sensory and responsible for vision. It transmits special efferent impulse of light to the brain. It consists of 3 parts: the intraorbital part, cananucular part, and intracranial part. It is not a true cranial nerve. It is a part of a brain. It is a tract of a brain, for it develops as an outer growth of the diencephalon during the embryonic life. Visual pathway starts from the retina, then the optic nerve, then the optic chiasma, optic tract, lateral genicular body, the optic radiation, and it ends in the visual cortex. Clinical anatomy, glaucoma. It occurs when the drainage of aqueous humor is affected and there is an abnormal increase in the intraocular pressure. Cataract is characterized by the opacity of the lens, and in this condition there is the clouding of the lens. When there is an injury to the optic nerve, it might result into temporary or permanent loss of vision, and there might be abnormal pupillary reflexes. Now, with the help of a video, we will summarize the anatomy of eye. The iris of the eye has in its opening called pupil, as located behind the anterior chamber. Iris muscle constrict or dilate the pupil. It controls the amount of light to enter. The lens is located directly behind the pupil. Light is directed towards the retina by the lens. The lens changes its shape to assist the eye in focusing on the object that are close. The vitreous cavity is located between the lens and the retina. It has special cells called photoreceptor cells, which are rods and cones. The cells convert light into energy and then send it to the brain. Rods and cones are 2 receptors. Rods detect the white and black and helps in the night vision, whereas cones enables the central vision and colors perception. Here are our references. Thank you.
Good morning. My name is Aniket Vyas, and I am honored to present at the 13th Undergraduate Combined Round Today, I will take you on a journey through the physiology of vision. This presentation was made under the guidance of Dr. Aparna Garg, Professor and Head, Department of Physiology, and under the moderatorship of Dr. Rosie Paul and Dr. Manshi Mishra. It is prepared by Shriyansh Gautam, Tanisha Garg, Vaishnavi Devarwal, Vanisha Goel, and myself, Aniket Vyas. The learning objectives are to understand the functional anatomy of eye, to understand the physiology of vision pertaining to image formation and color vision and color perception, the mechanism of genesis of photoreceptor potential in rods and cones, to understand the visual pathway and the applied aspects. The functional anatomy of eye is already discussed by the anatomy department. This figure shows the reflection of the light by the lens system. The light rays from the object pass through the cornea, the aqueous humor, the lens, and the vitreous humor to converge upon the retina to form an inverted image. The light falls upon the retina as shown in the light falls upon the retina as shown and stimulates the photoreceptors present there. The photoreceptors present in the retina are the rods and the cones. The rods are required for vision in dim light. They are highly sensitive to low light. They are required for black and white vision, and they have lower visual acuity. Acuity means the sharpness of the image formed. The cones are required for vision in bright light. They are less sensitive and thus require bright light. They are required for color perception, and they have higher visual acuity. The rods are rod-shaped and elongated. The cones are cone-shaped and tapered. The photoreceptors have three parts: the outer segment, the inner segment, and the synaptic terminal. The outer segment contains stacked disc-like membranes rich in photopigments. The rods contain the rhodopsin pigment and the cones contain the photopsin pigment. The inner segment contains the cell organelles such as the mitochondria required for metabolic activities. The synaptic terminal forms synapse with the bipolar cells transmitting the visual signals. This graph shows the concentration of rods and cones in the retina. The rods are represented by the red color and the cones are represented by the blue color. This graph shows that the rods are absent at the fovea and the concentration of the cones is maximum here. Due to this reason, the sharpest image is formed at the fovea, as the cones are the one responsible for sharpness of an image. When the light falls upon the retina, signal transduction occurs. Signal transduction is the conversion of the light energy into electrical impulse that can be interpreted by the brain. When the light falls upon the retina, chemical reaction takes place in the visual pigments, causing hyperpolarization of the photoreceptors. Thus, generation of receptor potential takes place. This receptor potential then enters into the visual pathway, which is as follows. The light ray falls upon the retina. The impulse is generated, which passes via the optic nerve to the optic chiasma, where crossing over of the nasal fibers take place. Then through the optic tract, it relays in the lateral geniculate body present near the thalamus. And then through the optic radiation, the fibers terminate in the primary visual cortex area 17, where image of the object is formed from the retinal input. Then the neural signals pass to the visual association area 18, where recognition and interpretation of the visualized objects take place. We all know that the color vision is due to the cones. There are three types of cones: the red cones, green cones, and the blue cones. The red cones detect long wavelength with peak absorbance at 560 nanometer. The green cones detect medium wavelength with peak absorbance 530 nanometer, and the blue cones detect short wavelength with peak absorbance 420 nanometer. The colors that we perceive are due to combination of different types of cones. The perception of color vision is due to the chemical reaction in the visual pigments, which generate the impulse, which travels through the retinal X ganglion to the parvocellular cells present in the layers 3 to 6 in lateral geniculate body. Then it travels to the V8 of the visual cortex area 17, where color blobs are present responsible for the perception of color vision. This figure is of the V8 of visual cortex area 17, and these are the color blobs. There are two more pathways without of which the physiology of vision is incomplete: the accommodation reflex and the light reflex. The accommodation reflex is helpful when we change our focus from a distant object to a nearer object, and the light reflex is responsible for the dilation or the constriction of the pupil, so that the adequate amount of light enters into our retina, enters into our eye, and thus the retina is not damaged. The perception. To conclude the image formation and the perception, first the light rays from the object enter to the eye, pass through the lens, then converge upon the retina, forming an inverted image. Then impulse is generated, which travels through the optic nerve, to the optic chiasma, to the optic tract, and to the lateral geniculate nucleus, and finally to the primary visual cortex. The various tools required in ophthalmology are the powered lens, ophthalmoscope, Snellen's chart, the Ishihara chart, the Jacob's chart. The powered lens is required for correction of the errors of refraction. The ophthalmoscope is required to view the internal structures of our eyes. The Snellen's chart is useful for checking the visual acuity. Ishihara chart for the color blindness, and Jaeger's chart for the near vision. The errors of refraction are myopia and hypermetropia. Myopia is also called as nearsightedness, in which the image is formed in front of the retina. The causes are either the eye is too long related to its focusing power, or the large curvature of the cornea. It is corrected by the usage of concave lens. Hypermetropia. In hypermetropia, the eye is formed behind the retina, and the reasons are either the eye is too short related to its focusing power, or the small curvature of the retina. It is corrected by the usage of convex lens. In myopic vision, the nearer objects are clearly seen, and in the hypermetropic vision, the distant objects are clearly seen. Color blindness is a genetic disease, and it is more common in the males. There are three types of color blindness: the green blindness, also called as deuteranopia, in which the green cones are absent; the red blindness, or the protanopia, in which the red cones are absent, and the blue blindness or tridanopia, in which the blue cones are absent. The other applied aspects are the age-related macular degeneration, the glaucoma, and the retinitis pigmentosa. Now, to summarize, the light enters into the eye through the cornea, and then enters the eye through the iris, through the pupil present in the iris. Iris is a pigmented muscular layer, and it passes through the lens, the vitreous humor, and finally forms an inverted image of the retina. In the retina, the light energy is converted into the electrical signals, which travel to the visual through the optic nerve to the visual cortex in our brain. Thank you.
Very good afternoon to respected dignitaries, faculty members, and all my dear colleagues. Today, we, the students of batch 2021, Ruksar Banu, Nishita Jangir, Kalpana Chivelia, Bhavya Chaudhary, and I, Bhavyanshi Vishnoi, are here to present the topic Epidemiological Aspects of Blindness. So, the learning objectives are magnitude, that is how many, distribution, that is where it is all distributed, the determinants, that is main causes of blindness and visual impairment, and prevention and control, like what other measures we can take to prevent the blindness. So how is blindness defined? Visual acuity of less than 3/60 or its equivalent is defined as blindness. The current WHO ICDS level of visual impairment includes near vision impairment and distance vision impairment. The near vision impairment presenting near vision acuity worse than 6/12 at 40 centimeter with existing correction. And the distance vision impairment includes mild category, moderate category, severe category, and blindness. Mild category presenting visual acuity worse than 6 by 12, moderate with a visual acuity worse than 6 by 18, severe with a visual acuity worse than 6 by 60, and at last blindness with a visual acuity worse than 3 by 60. Globally, at least 2.2 billion people have a near or distance vision impairment. As we can see in the following graph, the highest rates are found in Southeast Asia, Western Pacific, followed by Africa. Also, we can see that in India and China, the burden of blindness is the highest. Vision loss can affect people of all ages. 1.4 million children, 5.8 million aged 15 to 49 years, and 32.2 million people aged 50 years or more are all affected by blindness. Now we'll see the trends. So we have shown a prevalence comparison from 2010 to 2019. Here the blue line represents the 51.9% relative reduction in visual impairment compared to 2010, with decrement from 5.30% to 2.55%, and the orange line depicts 47.1% relative reduction in blindness compared to 2010, with a decrement from 0.68% to 0.36%, and the decrement is largely due to improvement in cataract surgeries and other eye care services. However, the number of people living with visual impairment is expected to increase due to population growth and aging these days. Now the problem statement India. Current prevalence of blindness is 0.36% as per the National Blindness and Visual Impairment Survey. The prevalence of blindness in all age groups is 0.36%. And the population aged 50 years or more is 1.99%. And the prevalence of severe visual impairment in all age groups is 0.35%, and in the population aged 50 years or more is 1.96%. Now we'll see the main thing, that is the epidemiological factors. So the first epidemiological factor is age. About 30% of the blind in India are said to lose their eyesight before they reach the age of 20 years, and many under the age of 5 years. Refractive errors, trachoma, conjunctivitis, and malnutrition are important causes of blindness among children and younger age groups. Second is gender. The higher prevalence of blindness is reported in females than in males in India. Malnutrition. Malnutrition is not only closely associated with vitamin A deficiency, but also with various other factors. Fourth is occupation. Several people working in cottage industries and factories are all affected by blindness. Fifth is social class. The people with lower economic status are more affected by blindness as compared with the people with higher economic status. Last is social factors. Quacks, poverty, poor hygiene, and inadequate health services are all included in this. Cataract is the leading cause of blindness around the world, followed by uncataract refractive errors, glaucoma, AMD, corneal opacities, diabetic retinopathy, and others. However, the cause of blindness in India is majorly contributed by untreated cataract, followed by non-trachomatous corneal opacities, cataract surgical complications, other posterior segment diseases, glaucoma, pityriasis, uncorrected aphakia, ARMD, and others. Now let's see the prevention of blindness. So, the prevention of blindness includes initial assessment, method of intervention, and long-term measures. Primary eye care. Primary eye care is provided at all the grassroots levels by locally trained primary healthcare workers. whose activities include providing essential drugs such as topical tetracycline, vitamin A capsules, eye bandages, shields, promotion of good dietary habits, promotion of personal hygiene, and also safety in general. Secondary eye care is provided in eye departments or eye clinics, in the PHCs and district hospitals. It is also provided in mobile eye clinics as depicted in the picture, and it involves definitive management of common blinding conditions such as cataract, trichosis, entropion, etc. The tertiary eye care provides sophisticated eye care such as retinal detachment surgery, corneal grafting, and other complex forms of management that are not available in secondary centers and is often associated with medical colleges and institutes of medicine. The long-term measures aim at improving the quality of life and modifying the factors responsible for eye problems. It includes sanitation, nutrition, adequate water supply, and personal hygiene. Now I'll tell you 9 measures which you can use to prevent the vision loss. First is eat right. Eat right to protect your sight. You can eat different types of fruits and vegetables such as spinach, kale, and also you can opt for non-vegetarian options like salmon and tuna to prevent vision loss. Second is get moving, because being overweight or obese will get you nowhere and it will only put you at a higher risk of diabetes and other visual problems. Third is speak up if your vision changes. If you feel any kind of visual changes, you should always talk to your family members or friends. Fourth, wear your glasses. Fifth, keep the germs away. Always we should wash our hands before putting them close to our eyes, and especially if we are putting any contact lenses. Sixth is gear up. Wear the right protection to keep your eyes safe, because many eye injuries can be prevented with better eye safety habits such as using protective eye wears. Seventh is wear your shades. You should choose sunglasses that block 99% or 100% of UVA or UVB, and that will protect you from vision loss. Eighth is give your eyes a break. 20-20-20 rule. It states that for 20 minutes, look 20 feet away for 20 seconds. It is helpful for the people who have longer screen time. And at last, say no to smoking. These are the references. Thank you so much.
A very warm good morning to esteemed dignitaries, respected faculty members, my fellow batchmates and juniors. I am Manshi Mishra. On the behalf of the Department of Ophthalmology, will be presenting the 13th UGCR on the topic Causes of Blindness. With the help of my fellow batchmates, Kinshu Agarwal, Avnish Sharma, Kashish Jangir, and Devang Singerwal, under the able guidance of Dr. Chaitanya Prakash Gupta, Professor and Head, Department of Ophthalmology, and Dr. Sarita Jain, Assistant Professor, and Dr. Lipika Mehra, Senior Resident, Department of Ophthalmology. The learning objectives of this presentation will be to define blindness and its different extrapolations by WHO and NPCB, along with to study etiology of blindness along with numerous factors influencing them. As per WHO, in accordance with comparable national and international statistics, in 1972 it was proposed a uniform criterion and defined blindness as visual acuity less than 3/60 or its equivalent. However, in 1979, the WHO added inability to count fingers in daylight at a distance of 3 meters to indicate vision loss less than 3/60 or its equivalent. Visual field less than 10 degrees, irrespective of the level of visual acuity, is also referred to as blindness. Now we'll explore the definition by the NPCB. In 1976, the NPCB defined blindness as presenting distance visual acuity of less than 6/60 or central visual field less than 20 degrees in the better eye. However, in 2017, after 4 decades, the NPCB changed its definition and adapted the definition by the WHO. Now, this is a table illuminating the differences between the definitions by the WHO and the NPCB. We'll take the parameter visual acuity as our base and explore the two. In the low vision area, we have two categories. In the first category, where visual acuity ranges from less than 6 by 18 to 6 by 60, this is called as low vision by the NPCB. In the second category, where visual acuity ranges from less than 6 by 60 to 3 by 60, that is referred to as economic blindness by the NPCB. In the categories coming under blindness, in the third category, where visual acuity ranges from less than 3 by 60 to 1 by 60, this is referred to as social blindness by the NPCB. Manifest blindness would be the fourth category, where visual acuity ranges from less than 1 by 60 to perception of light. And when there is no perception of light, which is the last category, that would be absolute blindness. The problem in general is basically globally we have around 180 million people which are visually impaired, out of which 45 million are blind. Now the thing is 80% of blindness is avoidable. So the major causes with their estimated prevalence would be cataract leading with 19 million, followed by glaucoma 6.4 million, childhood blindness roughly around more than 1.5 million, and we have other miscellaneous causes which we'll discuss further with a number of 10 million. Types of blindness broadly divided into 3 types: partial, complete, congenital. 6 types: partial, complete, congenital, nutritional, preventable, and curable. If we define them one by one, partial blindness, as the name suggests, patients tend to have some sense of vision, often termed as low vision. Complete blindness, where patients can't see or detect light. Congenital blindness, which refers to poor vision present since birth, includes inherited eye and retinal conditions and also non-inherited birth defects. Nutritional blindness refers to vision loss from vitamin A deficiency, might manifest as xerophthalmia in chronic stages. Preventable blindness, which can be easily prevented by identifying causative factors at the appropriate time. Curable blindness, vision can be restored by timely intervention. Causes for blindness by WHO, the leading causes are cataract, refractive errors, diabetic retinopathy, glaucoma, and age-related macular degeneration. We'll discuss them one by one. This is cataract, as we can clearly see the corneal opacity, which appears as a whitish, cloudy appearance in the lens. Second would be refractive errors. This is based on where is the light focusing, either in front of the retina, behind the retina, or at the normal spot. And based on them, we have numerous variations: myopia, hypermetropia, and astigmatism. Now, this is the image of the normal fundus of eye. We have a few features: the artery, the neuroretinal rim, optic cup, optic disc, vein, fovea centralis, and macula lutea. And changes in these normal features indicate some kind of problem. So the first one is diabetic retinopathy. As we can clearly see, we can see hemorrhages, exudates, and microaneurysms. These are the classical features indicative of diabetic retinopathy. Second would be glaucoma. Here the optic cup to optic disc ratio is changed. However, we can also see the thinning of the neuroretinal rim. Third will be age-related macular degeneration. We can see yellowish spots which are called as bruisings in the eye. Now we'll explore the causes of blindness ranging across different ages. So the first group we'll see is in the population more than 50 years. We'll illumine with the help of this pie chart. As we can clearly see, the leading cause is untreated cataract with a significant percent of 66.2%. Then followed by refractive errors and cataract surgical complications with a leading percent of 7.2%. And this would be the causes of blindness in the next group, which is population less than 50 years. This would be, the leading cause would be again non-trachomatous corneal opacity followed by neurological abnormalities. Other miscellaneous causes of blindness include injuries, infectious diseases, and non-infectious diseases. Injuries is basically traumatic accidents. We can see road traffic accidents, chemical burns, exposure to toxins, fireworks, fights, industrial accidents, and sports. Followed by infectious disorders, cytomegalovirus, endophthalmitis, histoplasmosis, acanthamoeba keratitis, rubella, shingles, syphilis, toxoplasmosis, and uveitis. And lastly, we have the non-infectious disorders, which would include the retinitis pigmentosa, retinopathy of prematurity, diabetes-related retinopathy, glaucoma, followed by liver, hereditary optic neuropathy. Now, as we can clearly see, cataract is one of the leading causes of blindness. So it would be nice to discuss more upon it. I invite my batchmate Devang to illumine on cataract. Thank you.
To development of an opacity in lens or its capsule. So through this image, we can easily differentiate between a cataract eye and normal eye. Here, white color opacity will be present in lens that will represent abnormal pupillary light reflex, while in normal lens there is no such white opacity will be present. Now, etiological classification of cataract. According to etiological classification, cataract are broadly divided into two categories. First is congenital and developmental cataract, and second is acquired cataract. Now, acquired cataract is further subdivided into 7 categories. That is age-related cataract, which is also called as senile cataract, traumatic cataract, complicated cataract, cataract in systemic disease such as in diabetic cataract, myotonic dystrophy, and galactosemic cataract, and then electric cataract, radiation cataract, and toxic cataract. Now, this image will show the normal lens, that will show the normal pupillary light reflex. And now I would like to discuss in detail about senile cataract. Senile cataract, which is developed in old age, and senile cataract are broadly divided into 3 types, such as nuclear cataract, posterior subcapsular cataract, and cortical cataract. Nuclear cataract, which is also called as central cataract, and in this the day vision will be affected more as compared to night vision. This image will show the nuclear cataract, in which a central white color opacity will present in central part of lens. Now posterior subcapsular cataract, and here it will be characterized by presence of white color opaque line at posterior region of lens, and in this also the day vision will be affected more as compared to night vision. Now cortical cataract, which is also called as peripheral cataract, and in this the night vision will be affected more as compared to day vision, and the pathophysiology of cortical cataract is hydration. Because of hydration, the laminar separation will be occurs. The cortical cataract will have 3 stages. One is immature cataract, second is mature cataract, and third one is hypermature cataract. Immature cataract, which is also called as uniform cataract, and it will be a grayish white color opacity will be seen in center part of eye, and it will be characterized by presence of iris shadow near the center, near the white color opacity. Here in this diagram, the black color crescent line will show the iris shadow. Now, if the hydration will remain continuous and swelling does not be treated, the immature cataract will result in mature cataract. This image will show the mature cataract, in which a pearl white color opacity will be seen in central part of lens, and the most common complication of mature cataract is phakomorphic glaucoma. In mature cataract, the iris shadow is absent. And now, if the swelling does not be treated and the hydration will remain continuous, it will result in hypermature cataract. And the most common complication of hypermature cataract is some luxation of lens. So in image of hypermature cataract, if we see, the white color portion will represent the cortex and the yellow color portion will represent the nucleus. Here liquefaction of cortex will be occurs, that will be result in shrinking of nucleus in cortex towards one side. Now the risk factors of cataract. As we discussed earlier, the age is most common risk factors for cataract, and this image will show the mature cataract, in which a pearl white color opacity will be seen in central part of eye. The second, due to the prolonged use of steroid medication through any route, either maybe a topical, oral, it will develop posterior subcapsular cataract, in which a white color opaque line will be seen in posterior region of lens. Now diabetes mellitus, that will represent the snowflake cataract, and here the center part will show us snowflake cataract. Eye trauma, that include the blunt trauma as well as penetrating trauma, in which we will see a rosette cataract. Now the fifth cause risk factors is ionization exposure radiation, such as exposure to the UV rays or infrared rays. It will responsible to develop posterior subcapsular cataract. In electric cataract, basically a punctate will be seen as subcapsular region, and it will be developed into mature part. Now the other risk factors are dietary deficiency, such as deficiency in protein, amino acid and vitamins, and smoking and alcohols are also risk factors for cataract. Now the symptoms of cataract. First, color seems faded, the blurred vision, glare from sun seems bright, consistent change in prescription of glasses, double images, and poor night vision. Now through this image, we can easily differentiate between a normal eye vision and cataract eye vision. In normal eye vision, a healthy lens allows for all part of retina to receive the image, while in cataract eye vision, a cloudy lens scatters light, causing an image that's out of focus and hazy. Now the treatment option for cataract. The surgery is only treatment option for cataract. Basically, we have two surgical options available. First is ICC, that is intercapsular cataract extraction, and second is ECC, that is extracapsular cataract extraction. ECC further offer three surgical options, that is SICS, that is a small incision cataract surgery. Second is phacoemulsification, and third one is flux, that is a femtosecond laser assisted cataract surgery. Now we will discuss in detail about the surgical process. First is ICC. Here a large incision is done over the limbus, and in this, along with lens, its capsule is also removed out. So this surgical process is not used in nowadays. Now second surgical option is ECC. In this, incision is done over the limbus and at a 10 to 2 o'clock position, and in this we will remove out the anterior capsule and nucleus with cortex, but posterior capsule will remain intact, and in this surgical process intraocular lens are also used. The major disadvantage of ECC that because of the incision over the limbus, suturing will be required in this process. Now SICS. A small incision will be done over a sclerocorneal, which will be ranges from 5 mm to 7 mm in size, and it is not a machine dependent process. And it is universally applicability, that means it will be available for all the type of cataract, that also include hard cataract. And it is a self-healing in nature, and the advantage of SICS over ECC that it is a sutureless surgery. Because of these features, it will be used for en masse population in nowadays. And now phacoemulsification. The primary advantage of phacoemulsification that a very small incision will be done over a cornea, and which will be ranges from 1.8 to 3.2 mm in size, and it is a machine dependent process, and intraocular lens is also used in this process. The major advantage of phacoemulsification that it also provides sutureless surgery, but the recovery rate of this phacoemulsification process is very fast, as well as it also decreases the chances of post-operative complication. Now the last surgical option is flux. It is a most advanced method, and in this we will use a laser, that is a femtosecond laser, and through laser we will make an incision over a cataract lens and extract it out from eye. Now, how cataract a community problem? First, major cause of blindness. In greater than 50 years, the cataract will contribute 66.2%. While the major cause of visual impairment, in greater than 50 years, the cataract will contribute 71.2%, and in 0 to 49 years of age, it will contribute 25.4%. So this pie chart, we can easily see a major contribution for blindness will be done only by the cataract, untreated cataract, that is 66.2%. Now barriers to uptake of cataract surgery. First, cost. Cost not just only involve the direct surgical expenses, but it also involves the indirect surgical expenses such as transportation, accommodation and lost wages. Second, no need for treatment. Basically, if cataract does not severely impair the daily activities of patient, then patient try to postpone the cataract surgery. That will worsen their condition, eye condition. Third, don't know where to go. Due to lack of knowledge as well as awareness, mainly in rural areas people, they actually don't know where they go for a treatment of their eye defect. Can see with other eye, and two old condition. Basically in old condition many systemic diseases are developed such as diabetes mellitus, hypertension and many others disease, due to which the patient does not go for cataract surgery. And the last reason is waiting for eye camp. Basically eye camp will provide the free of cost treatment. So most of the rural areas people as well as the people which have low financial condition are mainly waiting for eye camp. But this will sometimes condition their eye condition very severe. Now the program that will be run by Government of India to control the blindness in India is NPCBVI. That is a National Program for Control of Blindness and Visual Impairment. The goal of this program is to provide comprehensive eye care facility for primary, secondary and tertiary level of eye health care. And second, to reduce the prevalence of blindness in population from 1.38% to 0.31 by year 2000. Now plan of action. Extension of eye care services. Through eye camps and mobile eye units, development of multi-purpose district mobile ophthalmic unit and teleophthalmology network unit. Second, establishment of permanent infrastructures, and third, intensification of eye health education. Now the first image will show eye health camp in which a free of cost treatment will be available for eye defect, and second will represent the mobile eye health unit which is mainly for rural areas people. Now Vision 2020. It was first started by WHO in Geneva in Switzerland, and it was adopted by India in 2001, first in Goa. The aim of Vision 2020 is to reduce blind people to 25 million by 2020 and eliminate avoidable blindness also. The target for cataract surgery rate was 6,000 per million by 2020. Second, to have a visual outcome of 80% surgeries, more than 6 by 18. And third, intraocular lens surgeries for all. And fourth, YAG capsulotomy service at all district hospitals. This bar chart will show the successive trend of increase the number of cataract operation per million population in India with successive years. Now the strategic activities to control the cataract. First, primary screening. Basically, it will be done by the eye professionals to identify the cataract patient from given population. Second, case selection. Basically, those cataract patients will be selected which have seriously visual impairment and have impaired daily activities even after uses of glasses. Third, cataract extraction with intraocular lens implantation. And fourth, reduction of disease burden. For this, we will go for a disease-specific approach. Thank you.
Thank you.